Today, we're unpacking one of the most aggressive pediatric leukemias out there, B lymphoblastic leukemia with KMT2A rearrangement. We're going to dive deep into the WHO 5th edition criteria, bridging that gap between the underlying translational biology and exactly how it hits the clinic. To set the stage right out of the gate, we have to look at the sheer epidemiological weight of this disease. Get this, 70 to 80% of all infant acute lymphoblastic leukemias are driven by this one single genetic rearrangement. So when you're evaluating an infant under a year-old with acute leukemia, this is absolutely the heavyweight you have to look out for and manage immediately. Here's our roadmap for today. We'll hit the KMT2A genetic driver, run through clinical features and epidemiology, and break down the pathology and diagnostic workup. Then, we'll look at prognosis and MRD tracking, dive into targeted therapy with menin inhibitors, and wrap up with the differential of ALL versus AML.
All right, Section 1, the KMT2A genetic driver.
It's really fascinating to look at KMT2A not just as some mutated gene, but as a fundamental architect of embryonic hematopoiesis. You probably know it by its old name, the MLL gene, but KMT2A actually stands for lysine methyltransferase 2A. In a normal state, it's this crucial epigenetic regulator responsible for histone H3 lysine 4 methylation. Basically, it carefully orchestrates the expression of Hox genes to maintain normal stem cell self-renewal and guide proper differentiation. So, let's trace exactly how this molecular pathogenesis unfolds. The whole thing goes off the rails starting with a chromosomal translocation. In infant ALL, we're usually talking about the T411 translocation, which creates that classic KMT2A-AFF1 fusion protein. And this fusion, it acts as a massive dominant oncogenic event. It persistently activates the HOXA9 and MEIS1 genes, completely blocking normal B-cell maturation. The hematopoietic stem cells literally get frozen in this primitive state, which causes a massive expansion of leukemic blasts. And because this fusion is such a powerful driver all on its own, these leukemias usually carry a surprisingly low secondary mutational burden.
Moving on to Section 2, clinical features and epidemiology.
The clinical presentation here is often dramatic, requiring incredibly fast and intensive management. These patients, again, usually under a year-old, come in with fever, pallor, poor feeding, and bruising. On physical exam, you're almost always going to find massive hepatosplenomegaly and really significant lymphadenopathy. Plus, compared to your standard risk B-ALL, these infants face a substantially higher risk of central nervous system involvement. This means you're frequently looking at diagnostic lumbar punctures and aggressive early CNS-directed therapy. But the absolute crucial point clinically is hyperleukocytosis. We aren't just talking about slightly elevated white counts here. We're talking about extreme white blood cell counts that routinely blow past 100 times 10 to the 9th per liter, and honestly, often much higher. This aggressive proliferation brings massive, immediate clinical risks of leukostasis, where those blasts just sludge up the microvasculature, and of course, severe tumor lysis syndrome. Let's step into the lab for Section 3, pathology and diagnostic workup. While a bone marrow aspirate is going to show blasts with fine chromatin and prominent nucleoli, it's really the flow cytometry that paints the full picture. You'll see those standard B-cell lineage markers lighting up, like CD19, CD79A, and cytoplasmic CD22, right alongside CD38 and HLA-DR. And interestingly enough, we also frequently see aberrant expression of the myeloid marker CD15 in these infant cases. But you have to pay really close attention to this hallmark diagnostic finding, the distinct lack of CD10 expression. While TDT expression might be weak or kind of variable, this CD10 negativity absolutely cements the classic pro-B-ALL phenotype. Basically, if you see an infant with a CD19 positive, CD10 negative acute leukemia, KMT2A rearrangement needs to be sitting at the very top of your differential. To make sure our diagnostic accuracy is rock solid, let's contrast this against another classic pediatric leukemia, B-ALL with ETV6/RUNX1. Look at how completely different the clinical trajectory is here. ETV6/RUNX1 usually hits kids ages 2 to 5, features CD10 positive blasts, has lower white counts, and boasts a really excellent prognosis. KMT2A-rearranged ALL is basically its dark mirror. It's infant onset, CD10 negative, presents with massive hyperleukocytosis, is driven by the KMT2A/AFF1 fusion, and unfortunately carries a historically dismal prognosis.
Which brings us to Section 4, Prognosis and MRD Tracking.
Even with today's intensive, multi-agent chemotherapy and early CNS-directed treatments, 5-year survival for this disease remains significantly lower than standard-risk ALL. The adverse factors are pretty clear-cut: infant age, initial hyperleukocytosis, CNS disease at presentation, and that KMT2A-AF1 fusion itself. Because of this aggressive phenotype, our treatment is heavily dependent on tracking minimal residual disease, or MRD. We have to track it down to a deep sensitivity of 1 in 10,000 cells using flow cytometry or PCR. If you see persistent MRD, that is a massive red flag. It predicts an extremely high relapse risk and usually prompts an immediate conversation about allogeneic stem cell transplant.
But there's good news in Section 5, targeted therapy with menin inhibitors.
Enter menin inhibitors. Honestly, this is one of the most exciting recent advances in hematology, a true paradigm shift in translational precision medicine. Remember how we said that KMT2A fusion protein drives the disease? Well, to activate HOXA9 and MEIS1, that fusion protein absolutely requires a physical interaction with a protein called menin. So, by introducing a small molecule that blocks this specific KMT2A menin interaction, we can suppress the leukemic gene expression. We literally force those trapped leukemic blasts to finally differentiate, which leads to leukemia regression. It's a total game changer.
Finally, Section 6, differential, ALL versus AML.
So both of these leukemias shared the exact same 11q23.3 abnormality, the same HOXA9 activation, and the same menin dependence. But notice how this exact same underlying molecular mechanism creates vastly different diseases depending entirely on which stem cell actually acquires the fusion. If a myeloid precursor gets it, you see AML. This usually happens in children or in adults, often with monocytic features, MPO positivity, and it's driven by the T911 AF9 fusion. But if a B lymphoid precursor acquires it, you see infant ALL. It's CD10 negative, MPO negative, and driven by the T411 AF4 fusion. Same biological trick, completely different clinical entity.
So what's the major clinical pearl to take away from this explainer? Always maintain a high index of suspicion. If you're evaluating an infant younger than 1 year presenting with this classic triad, marked leukocytosis, CD10 negative precursor B-ALL, and severe hepatosplenomegaly, you need to immediately suspect KMT2A-rearranged ALL. Recognizing this early on allows for rapid cytogenetic confirmation, which is absolutely essential because this subtype requires highly aggressive, risk-adapted therapy starting from day 1.
And as we look to the horizon of targeted therapies, we have to ask ourselves a pretty profound question. As menin inhibitors continue to show such promising activity and completely redefine precision medicine, how quickly might their integration into frontline clinical trials rewrite the future for these high-risk infants? Could we literally be witnessing the beginning of the end for the historically dismal prognosis of KM2A-rearranged infant ALL? It is an absolutely fascinating space to watch.